Ladies and gentlemen, my name's Ian Norman, and it's my great pleasure to welcome you to the Florence Nightingale School of Nursing and Midwifery here at King's, and to our series of inaugural lectures which provide an opportunity to showcase and celebrate our new professors. So before we start though, just a few housekeeping points. Fire, we're not expecting a fire, so any alarms are likely to be the real thing. And so if the alarm rings, make your way to the front and you'll see it's very close actually. There's a big entrance which you've all come in, and that's the way we go out. Mobile phones. I wonder if I could ask you to just check that your mobile phone is switched off or switched to silent. Following the lecture at about 6:30, I would like to invite you to join us for drinks in Chapters, which is just nearby, where you'll have a chance to discuss the lecture and also to pin Jackie down with lots of questions. So I'm delighted this evening to introduce our new professor, Professor Jackie Sturt. Jackie qualified as a registered general nurse in Leeds and then as a mental health nurse here in London at Guy's Hospital. She worked as a nurse practitioner in the very well-known Burford Nursing Development Unit in Oxford from 1988 to 1992, when she began her formal research training. Jackie gained her first degree in politics and sociology from Oxford Brookes University in 1992 and a PhD in health studies at Brunel University in 1997. In 1999, she joined Warwick Business School as a senior research fellow and as part of a team evaluating 5 primary care research networks in London. And she later joined the Centre for Primary Healthcare Studies in 2000, which then became part of Warwick Medical School. And from 2002 to 2012, over 10 years, she developed a behavioural science programme of work in diabetes self-management, during which time she was the recipient of a prestigious 4-year National Institute for Health Research postdoctoral fellowship. In 2012, in September, she moved from the University of Warwick to join us here at King's in her current post of Professor of Behavioural Medicine in Nursing. Now, during her period in Warwick, Jackie did much to promote and facilitate patient involvement within diabetes research, and for 2 years she was actually seconded part-time to University Hospital of Coventry and Warwickshire, where she developed the Diabetes Listener Service for patients struggling to cope with their diabetes. And developing and evaluating behavioural interventions to optimise self-management in long-term conditions remains her area of expertise. And she's currently involved in working in diabetes, rheumatoid arthritis, and a range of other physical and mental health long-term conditions experienced particularly by young people. Now, in addition to all this, Jackie has also had a chance to get married and to have children, and in fact they're in the audience tonight with her husband and many relatives. So it's great to see them here, and I'd like to welcome them particularly to King's on this very special day. So Jackie's lecture this evening is entitled, "Would you like an appointment with the diabetes listener?" Ladies and gentlemen, please join me in welcoming Professor Jackie Sturt.
Thank you all for coming, and I'd like to convey my own welcome to you all, and my gratitude that you're here with me this evening to celebrate this occasion in my career. The Diabetes Listener Service, which I'm going to tell you a little bit about, began life at the Wisdom Centre in UHCW, the University Hospitals of Coventry and Warwickshire. And it began as following a serendipitous conversation I had in the car park at Warwick Medical School with Dr. Aresh Anwar, who's a diabetes specialist at UHCW. I'd been out of nursing practice for about 17 years. And during that time, I'd done a lot of research and also done a lot of teaching and developed a lot of teaching around patient self-management. And I knew that people with diabetes struggled to cope with it and that there was a need, a clinical need. And I felt that I had some skills. So I asked Aresh if there was a way of developing a service that could involve me. And 6 months later, well, at the end of the conversation, he said, "Great, you write the job description, I'll find the funding." And 6 months later, the Diabetes Listening Service was developed. It ran for 18 months between 2010 and 2011. And it was based on, the format of it were patients who were struggling to cope with their diabetes, who were just identified in clinical practice by their regular clinicians. And they had what I later understood was diabetes distress, a condition called diabetes distress. But at the time, for me, they were struggling to cope with their diabetes, and that's what the clinicians identified them as. So the service was a 6-consultation service over a period of about a year, and people could have 45 minutes with a diabetes listener during that time. So that was the structure of it. But before I talk more about diabetes distress, which is obviously what the Diabetes Listener Service was about, I'd like to tell you just a little bit about diabetes, because not all of you here is as familiar with diabetes as I am. So, excuse me while I drink. Diabetes is a big public health issue for the world, really. In the UK, we have 3.2 million people with diabetes right now. That's about 5% of the population. If you think about the United States, they have 25 million people with diabetes. That's a lot of people. And to give you an understanding of the size of the impact of that on our health services, if you think about everything that the NHS does, all the treatments it undertakes, all the maternity care that it provides, all the operations it undertakes, and all the investigations which are getting more and more sophisticated and more costly all of the time. If you think about all of that, diabetes costs 10% of the entire NHS budget. So with all those things also happening, diabetes is taking a huge amount of £10 billion a year it's costing. So it's a big public health and economic issue for the country, as well as a big issue for people living with diabetes. So what is diabetes? Well, there are 2 types. There's type 1 diabetes and there's type 2. And I'm going to talk you through this slide in a moment, but type 1 diabetes, of the entire population, type 1 accounts for about 10% of people with diabetes. Type 2 accounts for about 90% of people with diabetes. They both affect different types of populations, different people. Type 1 people are diagnosed earlier. Type 2, they're in life. Type 2, they're diagnosed later in life. And they have different reasons. But the underlying consequence of the reason why they have diabetes and the implications of them having diabetes is they are living with too much glucose in their bloodstream, and that's fundamentally the problem. So what happens is we eat food in the form of carbohydrates. So this is a little anatomy and physiology lecture slot for those who are not so familiar with it. We eat food which is in the form of carbohydrates sometimes, and that turns into glucose, and that gets into our bloodstream. We need, all our organs and our cells need glucose in order to function, in order to our heart needs it to pump, my hand needs it to do that. We need glucose. And when glucose is detected in the body, in the bloodstream, insulin is produced, and insulin is produced by the pancreas, which is where the red arrow is pointing. So insulin is produced in response to the presence of glucose in the bloodstream, and what happens in a person that doesn't have diabetes is the insulin unlocks a key so that the glucose can get into the cells that require it. So here we can see that this is where we start to differentiate the two different types of diabetes. In type 1 diabetes, the beta cells that we saw in the previous slide stop producing insulin over a period of about 6 months. It's type 1 is an autoimmune disease, and the beta cells just stop producing insulin. So we have a cell with a lock, we have glucose that wants to get into that cell, but with no key. So the insulin has gone, so with no key to let the glucose in. So that insulin has to be replaced by artificial insulin. In type 2 diabetes, insulin is very often still being produced by the pancreas, by the beta cells. But the issue, there's a reduction in the amount of insulin, but there is also the issue that the lock has changed. So we still have a key, we still have the insulin, we have the sugar, the glucose that wants to get into the cell, but the lock has been changed, and we call this insulin resistance. And so we need treatments in order to enable the glucose to get into the cell. This is my final slide on diabetes physiology. I'm going to be talking a lot in the next half an hour, 45 minutes or so about blood glucose. And I'm going to use all these words that are up here. I'm going to talk about blood glucose, I'm going to talk about HbA1c, and I'll probably use the term glycemic control. Essentially, they all mean the same thing. It's about the amount of glucose that's in the bloodstream. Here are two pictures of red blood cells. On the left-hand side, the red blood cell has got glucose attached to it, a smaller amount of glucose attached to it. Glucose travels around the body to all the cells and organs that require it, attached to red blood cells. In the blood cell on the right, we've got rather a higher amount of glucose attached to the red blood cell. And this is where we start to have a problem with people with diabetes, in that if people live with too much glucose in the bloodstream for too long, for a period over years, then this leads to complications, which accounts for the NHS expenditure that I talked about a few moments ago. So it leads to complications. In the UK, high blood glucose levels or diabetes is the most preventable cause of vision loss. It's the highest. It's the reason why the reason why people have vision loss that's preventable. Also in the UK today, we are performing about 100 amputations every week on people with diabetes, and that is because people have got complications of the diabetes from having too much glucose in the bloodstream for many years. So the fundamental aim of treatment for diabetes is controlling and managing this glycaemia, this blood glucose level in the bloodstream. So how do we do that? Or how do people with diabetes do that, and with the help of healthcare professionals? The treatment is complex. The management, really, I guess, is complex. If you have diabetes, you have to take tablets, you have to take insulin. Oh, you may have to take insulin, you have to test your blood sugar level, you have to prick your finger several times a day and test your blood sugar readings. You have to think about what you're eating all the time and how much of that you're eating. You have to think about how much physical activity you're taking. Are you taking enough? Are you taking too much? You have to go to lots and lots of different appointments to be monitored. You have to have your blood pressure, your heart, your feet, your eyes, and of course your blood glucose levels monitored on a regular basis. So managing this condition can be very overwhelming for people. There's a lot to think about, and people are doing this on their own. So there's all this management activity, but people are probably have 2 to 3 hours with a healthcare professional a year. And these are things, these are activities that people with diabetes don't just think about every month or so. It's not even every week or so. It's every day, and for many, it's every hour. These things need thinking about all of the time if they're going to live well. And if people only have 2 or 3 hours with a healthcare professional, they're on their own with this quite a lot of the time. This becomes overwhelming. And on top of all of this management activity, all these things people have to do, pretty much everybody in their life at some stage, their family, their work colleagues, their friends, and society as a whole, everybody has an opinion about how they should be managing their diabetes. Have you had your appointment? Have you taken your insulin? Have you tested your blood sugar? Should you be eating that? These are things that, this social monitoring within families and with society that goes on within the person's life with diabetes. And this is what results in the diabetes distress that leads to people struggling to cope. Colleagues of mine in the University of San Francisco, California, Bill Polonsky and Larry Fisher, have been doing a lot of work to try and understand diabetes distress and the domains. What is it that causes the distress or the experience of distress, and what are the domains of that distress? And they've done this. We've had instrument scales to measure distress for about 20 years. And so we have got a lot of data that we can draw on in order to try and understand statistically what these domains of distress are. And there are 4 of them. There's condition distress, treatment or regimen distress, there's social relationship distress, and there's clinician relationship distress. And I'm sure that I've spoken probably about the first 3 in my introduction to diabetes. You'll get a sense of what those distresses are around. One that those of us that are healthcare professionals need to think about is also the clinician-related distress, which I haven't spoken about yet. If people only have 2 to 3 hours with a healthcare professional in any one year, and they've got all of this management activity to undertake and to perform, if they go to an appointment with their nurse or their doctor and they don't get their needs met, then that is that's a missed opportunity for that person. That is distressing for the person with diabetes, because their clinician has not been able to meet their needs and answer their questions, and this leads to a considerable amount of distress for the patient. I'd like to tell you about 2 of my patients that attended the diabetes listening service. I'd like to talk to you about Kate and about Ted. Kate was 27 years old when she attended. She'd been diagnosed with type 1 diabetes when she was 20, and her perception was that nobody had really taken much interest in her diabetes when it was diagnosed, and so as a consequence, neither did she. She now lives with her partner, and she has a mum and she has a sister, and she talks to none of those people at all about her diabetes. She's very isolated with it. She's injecting herself with, and she's testing. Well, one of her problems is she's not testing, but she's taking her blood glucose, she's taking insulin, and she's attending appointments, but nobody in her family is asking her about it, and she's not communicating with her family about any of that. So she has a social relationship distress. She's very isolated with her diabetes. In addition, she's giving herself insulin, but she's not blood glucose monitoring. And because she's not blood glucose monitoring, she's guessing her insulin doses. She doesn't know how much she needs, so she's just taking an eeny, meeny, miny, mo amount, which means that most of the time her blood glucose levels are very high. And she describes feeling stupid and guilty about this. She knows that she should be monitoring, but she just feels stupid that she's not. She's almost sort of paralysed with it, really. She's learnt enough in that 7 years of having diabetes to recognise that when she has tingling in her fingers, that might be a complication of diabetes, and she starts to get worried that she's developing complications at 27 and that her health is deteriorating. Ted, who was one of the other patients, he's 64 years old. He had been diagnosed with type 2 diabetes for 20 years. And Ted has a, he presented to me with a increasing weight over the previous year or two. And so weight going up and her blood glucose levels going up. And he's also got spinal problems, which gives him pain. He's got sleep apnea, so he's not sleeping very well. And he does have also some diabetes complications that have started. He's got some peripheral neuropathy. He looks after his wife, who's disabled. He's her main carer, and he also looks after his 2 grandchildren a couple of days a week as well. And Ted is really worried because he feels that his health, he's got a lot of responsibility on his shoulders, but his health is at that tipping point where it's like the funnel. He's deteriorated and he's going down the funnel, and he's worried he's getting to the point from which there's no return, and he's not going to be able to climb out of this funnel and regain his sort of some control over his health if he doesn't take some action soon. So they came to the Diabetes Listening Service, and this is the framework that informed the Diabetes Listener consultations. It was, we call it the Pathway to Behaviour Change. I developed it when I was working, well, some colleagues and I developed it, Rosie Walker and Judith Carpenter and Charles Fox, and we developed the pathway as a self-management program at master's level. And it's all evidence-based, so it starts with establishing relationships. If you're going to work therapeutically with someone, you need to have a relationship that enables them to trust you. So as their healthcare professional, I very much used Carl Rogers' person-centred counselling work in order to communicate unconditional positive regard, empathy and genuineness. And once that trust was established, people are able to start moving around with their feelings and their beliefs and their confidence. And this is what Kate did. Kate moved around in those consultations, trying to understand her isolation, trying to understand why she couldn't do something about her isolation, trying to understand this guilt and this stupidity that she was feeling. She was feeling guilty because she wasn't blood glucose monitoring, and she was feeling stupid because of it, but she just was unable to do anything about it. People moved through the pathway or along the pathway. I'm depicting it as a circle here, but that's just for the benefit of the slide, really. But people move around that at different paces. So people sometimes would move from along the pathway within a consultation quite quickly, but also some people would, people get stuck at various places along the pathway. And Kate, in fact, did get stuck at the feelings and beliefs and confidence stage. She really, every time she came back to a consultation, she still had the same amount of distress, she still had the same amount of feelings of inadequacy about managing and her diabetes. She also had a depression which was impacting on her ability. So she had lots of intentions. She would go away each time saying, yes, I'm going to start monitoring, but the next time she came back a month later, maybe she hadn't able to move any of that forward. Ted was a very different kettle of fish. He moved along the pathway much more quickly. When he came to his first consultation, what he was worried about was his wife's response, his need to be well so he could care for his wife. It was the responsibility and of his caring role that worried him, and whether he could continue to do that given his deteriorating health. He was also acknowledged that he would spend quite a lot of time on his own once his wife had gone to bed in the evenings. So he was comfort eating in the evenings, and that was hence the weight gain and the high blood sugar levels. This was all articulated at the second consultation. The first consultation. We talked about his feelings, his belief, and his confidence. By the time he came back to his second consultation, he'd already engaged on a weight management programme that had been, was being run by his GP practice. And he sort of moved very rapidly around this, along this pathway. And at the point of his discharge, 6 months later, he'd lost quite a lot of weight. His blood glucose levels were much closer to where he wanted them to be. Because his weight had reduced, his spinal problems and his sleep problems were starting to feel better, and he was starting to make progress in resolving those. The connection between the physical and the psychological health and the management of physical health burdens with these emotional approaches were very, very present to me and very apparent when I was undertaking this role as a diabetes listener, although none of it was new to me. I experienced the strong connection between the physical and the emotional in terms of health from the point at which I started my nursing career, which was at Manaland Sue Ryder Home in West Yorkshire. I was 17. And I worked full-time as a nurse cadet, or as a canary, as they called me. This was at a point when the hospice movement was very young. So there was, it was an interesting time in retrospect to be in the hospital, to be working in a hospice. You'd be pleased to know I do still cycle to work, although these days it's on a Boris bike. So. In these photographs, you can see this was at the annual garden party of the Sue Ryder Home, and as the youngest member of staff, I was asked to push Fred's wheelchair as he presented a bouquet of flowers to Lady Sue Ryder, who's the lady in the blue and white headscarf, on the occasion of her visit to open our annual garden party that year. I think that when I look back on my time at Manalands, I think it was in retrospect, it was a very mindful place. I now know a lot about mindfulness and that sense of living in the moment and using that as a therapeutic approach in order to try and alter the way that you think about things. And at Manalands, obviously, all the patients were in the last weeks and days of their life, and they were cherishing all those final moments, as was their family. And I think that the nursing staff also were doing this. We were cherishing those moments with them. We were working in the present and in the day in order to help them to have their last moments and support them in their own mindfulness, I think. And certainly the healing effects of emotional caring on physical health burdens was very apparent to me from the moment I put on a uniform and somebody called me nurse. And I'm very proud of these compassionate and caring and fun nurses that taught me many of those fundamental lessons in that first 16 months of how to be a nurse. And I'm very grateful for that. My family began a long association with Manalands and the Sue Ryder Foundation. Mum quickly became a volunteer, and in time was to be awarded her 20-year-long service award from the foundation. In 1980, I began, as Ian has told you, I began my nurse training in Leeds at Jimmy's. And I was always drawn to medical nursing and spent quite a lot of my training here in Beckett Wing, which was the medical, obviously it wasn't by choice, that's where I was sent, but I was just fortunate I was sent to a place I wanted to be. My final year student placement on the medical ward transitioned very smoothly into my first staff nurse post on the same ward. And an early conversation with the nursing officer at the time, in which I found myself articulating that in order to be a good medical nurse, I really needed to understand more about how the mind works, and therefore I was going to quickly do my mental health nurse training so I would be able to be a better medical nurse. And it was 6 months later, I was to find myself at Guy's down the road, undertaking my mental health nurse training. In 1988, I decided I needed a degree, and began a degree in politics and sociology at the Oxford Brookes University. And at the same time, I took up a post at the Burford and Oxford Nursing Development Unit as a nurse practitioner. And it was still some years before I was going to learn about Albert Bandura and his self-efficacy theory. But I know that when I got to Burford, I had a very strong vicarious learning experience. What I found when I got to Burford were nurses that were undertaking master's degrees, and this is in 1988. And I found nurses who were doing their doctorates, and there were nurses who were publishing. And this was, I didn't know that you could do this if you were going to be a nurse. And so there were very strong vicarious role models for me in that place that really, I think, probably set me on the rest of my path academically. It wasn't long before my own first publication was to join them. It was a literature review. I called it the salt bath myth, because nurses, wherever I worked clinically, one of my very early questions was, do we use salt in baths on this ward? And a number of placements down the line, I kind of thought, why am I asking this question? Why are we even, what's this thing about salt in baths? Is it a habit? Is it, and so this was a literature review to understand the literature around what's the healing properties of saline baths, basically. A few years later, and I was to study for my PhD with Professor Sally Kendall, and here I learnt behavioural science. I taught myself through my PhD the behavioural sciences. My first proper postdoc post was, once I got my PhD, was at Warwick Business School, where I joined a research team, and shortly after that, the Centre for Primary Healthcare Studies at Warwick which became Warwick Medical School. And during this time, I was very, very brilliantly supported by colleagues in the Centre for Primary Healthcare Studies, Jeremy Dale, Francis Griffiths, and Hilary Hernshaw, who was my fantastic mentor. Ian mentioned I had a 4-year postdoc NIHR fellowship, and Hilary was the person that helped me prepare for that and saw me all the way through it. So I'm very grateful to Hilary, and I'm pleased that she's with us this afternoon, or with me this afternoon. So at this point, I'm a fairly new postdoc researcher. This is what life looked like at the time, and those of you that can see the front row, they're a lot bigger now. So you will have noticed from my title slide and that I'm Professor of Behavioural Medicine, and you might be thinking, well, what's behavioural medicine, what's behavioural science? And for me, behavioural science or behavioural medicine is the clinical application of the body of knowledge around health psychology. And we need to understand human behaviour because we need to know why people do things. We need to know why they do things and why they don't do things. And we need to know, we need to be able to work out how we can assess, how we can measure what it is people are doing and the outcomes of various interventions. And we need to develop those interventions so that we can influence the health behaviours, the health behaviour choices that people make. And I've always been a believer. I'll turn the slide because I can see my family grimacing in the front row, and now I've turned it off. There we go. We'll be happier with that one. I'm a big a believer in experiential learning. So I would like to demonstrate with you, I'd like your participation to demonstrate some behavioural science now. So I'd like you all to think about a health behaviour change or a health behaviour that you've all been thinking about. So individually, think about something that you've been thinking about for the last 6 months or so. Either a health-related behaviour that you've maybe started to do something about, or maybe something that you're thinking about doing something about. And just to help your thinking, if nothing's quite coming to mind as a personal health behaviour, I've put this slide up because it's absolutely a brilliant slide, and I would really encourage all of you to go away. It's on the Cancer Research UK website, and it is so fantastic. And what it actually does is the S is made up of all sorts of all the different cancers, and the caterpillar at the bottom are all the different health behaviours that contribute to the development, and the evidence base about the different health behaviours that contribute to the development of different cancers. And just because it's quite difficult to read, I've listed them on the right-hand side. So as you're thinking about your own health behaviour, if there's anything that if you're struggling to even think of an idea, just cast your eyes up and down there and just think about something. And I'd like to ask you at this point, please, if it's possible for you all to stand up. Okay, thank you. So, thinking about your health behaviour, the one that's in your mind that you've been thinking about or actually changing in the last 6 months, I'd like to think how important, on a scale of 0 to 10, how important is that health behaviour change to you? And that's in the context of everything else going on in your lives, in the context of studies and work and family life and caring responsibilities and all the stuff that's going on. How important is that health behaviour to you? And if you can think of choose a number between 0 and 10. So if that number is 7 or above, then please remain standing. If your number is 6 and below, please sit down. Few. Always a bit of a risk. Okay, next question. For those of you that are standing, can you think about the same scale, 0 to 10, how confident are you that you can either maintain this behaviour or initiate it, if you haven't already initiated it? How confident are you that you can do so for the next 6 months? Again, the same scale, 0 to 10. Think of a number. How confident are you that you can do it? You see, 10 is most confident, 0 is least confident. So if your number is 6 or below, please sit down. Thank you. So, colleagues, what I've just demonstrated there, and friends and family and colleagues, is that some techniques that we use in something called motivational interviewing, which is an evidence-based approach to coaching people with behaviour change when they're ambivalent to change. So I'm going to ask, the next question is, if you have been making this change alone, so you've not been doing it with a partner or a friend or anybody else, if you've been making this change on your own, or if it's the first time you've made a change that's similar to this. So if you've been doing it on your own, or it's a bit of a novel experience for you, sort of making a health behaviour change, then please sit down. Yeah. If you've been doing the behaviour change on your own, or if you've no experience of making a behaviour change previously. So if you've been doing it, the reverse is, if you've been doing it with somebody, or you've made a behaviour change before, and this is another one, then remain standing. So everyone, those of you that are standing, are ready to make a behaviour change. You've demonstrated that it is important enough for you, and you're confident enough that you can make that change. And you've also developed strategies to support your own self-efficacy or your own confidence to self-manage. By doing it with other people, by building on previous experiences, by doing it with other people, you're developing a vicarious learning experience, which is supporting your confidence. By doing it by building on what you've done before, you're having a mastery experience. So you're all, I would say, those people that are now standing are all, I'm very confident that you're going to achieve your behaviours so you'll have a go, you'll stick to it. When you fall off the horse, you'll get back on again and carry on with it. So thank you very much for participating. So a lot of the interventions that I've been developing over the past 10 years or so have used strategies like that. They've incorporated text, or they've developed, or I've trained healthcare professionals to use those devices and those techniques to help people to work out where they are in relation to behaviour change. We can see people stood up and sat down at different phases. For some people it was important, but they didn't have confidence. For some people they were confident, but they didn't think it was important. For some people it was important and confident, but they were doing it on their own, and they were more exposed in their endeavours. And our patients are like this. We can't expect everybody to respond in the same way to an intervention that we might be trying to develop with them or to test. And I've been developing quite a lot of interventions over the past 10 years or so that are aiming to help people with long-term conditions to develop skills and confidence and self-efficacy to manage it. And I just would like to take a moment to thank this group of people here, who are some of the members of the Warwick Research and Education User Group. And I worked with this group and their colleagues, because obviously this is a snapshot, but there were many other people who came and went during that period, the decade that I worked with them. And they all worked very hard with us to develop the research programmes and develop the interventions, and I'm very grateful for their time and their commitment and their ideas and their energy, because they were really very brilliant people, and I really do thank them. One of the interventions that they worked with myself on was the Diabetes Manual. This is a self-management programme for people with type 2 diabetes who were, and it was an intervention that consisted of a workbook and the elements that you can see there. This was published in Diabetic Medicine in 2008. Once we developed the programme with the user group and with healthcare professionals, we wanted to evaluate it. So going right back to the early part of my lecture, when I talked about diabetes distress and I talked about blood glucose levels, what we wanted to do with the Diabetes Manual was to see whether or not, in a randomised controlled trial, if it reduced people's blood glucose levels, if it reduced their distress, and if it supported their self-efficacy. Did their self-efficacy improve as a consequence? We recruited 45 GP practices across the West Midlands, and 250 people with type 2 diabetes who undertook the study. And colleagues that I'd like to thank that were involved in this with Jeremy Dale, Francis Griffiths, Hilary Hearnshaw, Andrew Farmer and Sandra Eldridge, and they were all very great colleagues from who I learnt a lot during the process of this, my first randomised controlled trial. So I'll just talk you through the findings now. This is a busy slide, so I've tried to help by putting in red what I want to draw your attention to. So the group was randomised into two groups, an intervention group and a control group. And we evaluated self-efficacy, diabetes distress, and HbA1c. And you can see from the circle here that the programme did statistically significantly reduce distress and it did improve self-efficacy or self-confidence to self-manage. But it didn't reduce HbA1c. It did reduce HbA1c, but the between-group differences weren't statistically significant. So we can see that we had a program here that was partially effective. But what was interesting is when we looked at, just as you responded differently to the questions I was asking you, people in the trial also responded differently. So we had some people who absolutely stuck to the program from beginning to end, and they executed it in the manner that was intended. And these are the people who you will see in the pale blue figures on the last line. Their blood sugar levels were reduced clinically significantly at 6 months. By 6 months, the program was all over. There were no more healthcare professionals interacting with them on this matter. They've been it's a program that's very self-directed anyway. By this stage, by 6 months even, they were sort of on their own with it. By 12 months, the program was, very much over. But you can still see that their blood glucose control had only risen by a very small amount 12 months later. So in this group that did engage with it and did stick with it, it did make a difference. But we know that people are in different places to change. And the other people that were in the study, we had 28% of them that were information seekers. So they read the materials that we provided, but then they just kind of put them on the shelf and didn't really do anything with it behaviourally. We had a big group, 42%, who were what we call browsers or dippers. So they might start with the program and move along it for in the way that was intended, but then life got in the way. They got ill, they had a holiday, they got busy at work, these things that stop us with our habit formation. And the engagers, which is the group that did improve their blood glucose control on the previous slide, they accounted for 30%. So when we're thinking about interventions, we really have to be thinking about where people are at, and we have to be so person-centred in order that people get the most out of an intervention, and we target interventions at people for different phases and different relationships to change. One of the other things that we did during this diabetes manual study is we did some qualitative interviews with patients, and the patients had been given quite a lot of what I call the hardware, the materials. They'd be given a workbook, and they'd be given some CDs to listen to, and they'd also be given telephone support calls and a contact with their practice nurse. And this was the practice nurse that worked with them with their diabetes the whole time. This was not a stranger to them. This was someone that they knew fairly well. And in the qualitative interviews, the patients talked very positively about the hardware and the impact that the hardware had had on their management of their condition. But none of them mentioned the role of the nurse and any difference in the way in which the nurse had been engaging with them. And this was kind of curious because we trained these nurses for 2 days specially in order to deliver psychological and behavioural care to people, care that's informed by psychology and behavioural science. And but it wasn't coming through to the patients. And when we this was at a time when there was a lot of evidence being produced in the NHS that the emotional burden of diabetes was increasing. There was an increasing amount of evidence, and also we knew that at the time there weren't many psychological specialists in the NHS either. There are more now, but there weren't very many then. So nurses were the obvious answer to meeting this need. Nurses would be able to provide this care. And yet we weren't seeing this in our interview transcripts. 2 particular pieces of research have been published which really took me to the next step in my research. These 2 studies have been published by colleagues here at King's, Khalida Ismail and Kirsty Winkley. and they had looked at whether psychological interventions could reduce HbA1c. So these are randomised groups, if you delivered a psychological intervention, would it have an impact on blood glucose control? And this is the type 2 study, and we can see, I know if you're not familiar with looking at forest plots, the fact that the diamond is to the left of the centre line indicates that it is a statistically significant finding favouring the intervention. So a psychological intervention reduces blood glucose control in people with type 2, and this was published in The Lancet. The second paper by the same team was published in the BMJ, and they found that they looked also at children and adolescents to this. The adult finding was a bit more equivocal. It did cross the centre line, but the children's finding was to the left. So if you give children and adolescents a psychological intervention, then it is likely to have an impact on lowering their blood glucose control. And when all the studies were put together, then we found a positive overall effect. I was very intrigued with this research, and I wanted to know whether or not who'd been delivering these interventions, and whether nurses and general clinicians had been delivering the psychological interventions, or whether it had just been psychological specialists. And so colleagues and I undertook an update of this review to add more studies to it, to look at the difference between if you look at whether psychological specialists deliver the intervention, or general healthcare professionals, by which I mean GPs, practice nurses, diabetes specialist nurses, dietitians, not psychologically trained healthcare professionals, would that make a difference? Does it affect the outcome? And we can see by the findings here that it affects it marginally. So nurses are almost, or nurses and general clinicians, are almost as effective in delivering psychological interventions as psychological specialists in these studies. So we now know that nurses and other general clinicians can do it, and we know that the size of the problem is growing. Before I return to the title of the talk and the Diabetes Listening Service, I just want to tell you about one further piece of research that takes us back to diabetes distress and the reason why all of these psychological interventions are necessary. I've been working with a colleague here, Catherine Dennick, and Daniel Hessler and Larry Fisher at UCSF to do a big systematic review of the diabetes distress literature that has been produced. We've been measuring diabetes distress for 20 years, and that literature has never been brought together before. Diabetes distress has also never been the target of a primary outcome of a study. So until recently, we haven't targeted distress by our intervention. We've measured it, but the intervention has been targeting something else. So we've been undertaking this large systematic review with 16,000 citations, which is a huge amount, I can tell you. And we've had to look at 1,000 full-text papers, and we now have 41 randomised controlled trials in this review. And this hasn't yet got to. We're writing the paper now, so this is sort of hot off the press findings. From the 41 included trials, we extracted data on the interventions that have been used to reduce distress, diabetes distress. And from a content point of view, we looked at diabetes self-management interventions, psychological interventions, psychoeducational, and some miscellaneous ones. And we defined, so the difference, for example, between psychological and psychoeducational would be that the psychoeducational has a psychological intervention, has an educational component, a diabetes-focused component, but it also has a component which addresses mood or motivation. So that's the psychological element. The DSME one has no psychology in it, and the psychological one has no education in it. We looked also at extracted data on the medium of those interventions, how they were being delivered and who they were being delivered by. And here is some headlines from the review that we've just found. So the forest plot at the top is, these are the significant findings. So I'm not showing you the non-significant findings, only the significant ones. So we know that out of the list that I just showed you on of the content on the left-hand side, the only significant finding was of psychoeducational interventions, where there's diabetes content and mood or motivation content, and that reduced distress. We also found that face-to-face and remote element interventions were significant as well. So that remote element might be email, it might be telephone, it might be via a web portal, but having a face-to-face relationship, but also an ability to access your healthcare professional outside of a clinic appointment was important and effective. These are some of the other statistically significant findings. Probably just drawing your attention to the bottom one. This literature is mostly type 2 studies. There are type 1 studies in there, but they are mostly type 2. The general healthcare professional at the bottom, these weren't even diabetes specialists. These were GPs and practice nurses and community matron type roles. And that had the biggest effect size in terms of reducing distress. So if an intervention is delivered by someone in the community to people with type 2, it had a more likely, a bigger effect size. So these were studies where we measured reduction in distress and reduction in HbA1c by the intervention. So motivational interviewing reduced HbA1c and distress, as did mood focus, again face-to-face and remote, and a greater number of sessions, so more intensity to the intervention. So back to our person with distress. The second question that we asked in this review is, how prevalent is it? How many people are experiencing diabetes distress? And what we found is in community populations, so primary care populations, that we find it's between 12 and 15%, and in hospital populations, which is mostly people with type 1 and people with type 2 that probably have complications or are taking insulin, the prevalence goes up to 25 to 30%. These are research populations, research study populations. So in terms of the size of the problem that we're facing, we know that going back to the beginning, 3.2 million people in the UK have diabetes right now. If we take the most conservative of these estimates and we go for the 12%, that still means that right now, today, there are 300,000 people with high distress, and all those 300,000 people will almost certainly all have seriously high blood glucose levels, which will be taking them down that path, down that funnel that I talked about earlier in relation to management of their health. But there's some good news from this review, and that is we now have the review has given us some signposting. We know that psychoeducational interventions will seem to be more helpful. We know that general clinicians, certainly for type 2 populations, are effective, and we know that across type 1 and type 2, general clinicians are effective from the Khalida Ismail's work. And we know that in terms of how do people want their contacts, that they want face-to-face, but they also want remote elements too. They want to be able to contact their healthcare professional when they need to. So just to answer that last question of who, I'll take you just back for the last few moments to the diabetes listener case notes. So during the 18 months that I was a diabetes listener, people who were struggling to cope, and that was the only brief that healthcare professionals were asked, people who were struggling to cope. 82 people were referred, and that resulted in over 200 consultations. And of those patients, 42 people attended more than 2 consultations. So we went through parts of the behaviour change pathway with them. They progressed or not along that pathway. And what I'm going to show you, what I'm going to talk about for a moment is Lisa and Robert. And Lisa and Robert are typical of the 42 people in this data set. So Lisa and Robert, they differ slightly on some, we've got a man and a woman, they've both got type 1. Lisa's PAID score, her distress score, is lower than, it's significantly over the cut-off, the threshold, which is 40, but in contrast to Robert's, which is very, very high. Lisa has diabetes distress, Robert has diabetes distress, and he has a major depressive disorder, so he's got diagnosed depression. At the first appointment, these are notes taken my ex-PhD student and now colleague, Kate McCarthy, has been working with me on this, and she's been analysing these case notes. And you can see that these two individuals present quite similarly. They've both got fear of complications, they're both isolated with their diabetes, and they're both missing elements of their treatment. They're missing insulin doses, or they're avoiding monitoring. So they present quite similarly. By the second appointment, Lisa, our female, she's commenced monitoring, she's not so isolated, she's starting to do things about her diabetes. She's wandered around in the consultation with her feelings and her beliefs, and she's now been able to move some actions forward. Whereas our Robert, our male patient, he's still not able to move around at all. He's very stuck. He's not monitoring, he's not taking medication, he's run out of medication, and he's not taking any, keeping any other healthcare appointments. So, and this is typical of the data set that we have. We can see that there are people who have diabetes distress and depression, and they are stuck, whereas people who have diabetes distress alone are able to move forward. So, in answering the question of who, we know that we have to focus some of our attention on people who are struggling to cope. We have to assess for major depressive disorder and refer appropriately for treatment of depression, and we have to assess for diabetes distress and treat as above. So in closing this lecture, I hope that I've managed to communicate some of my passion for diabetes and for people who are living with diabetes. And I hope I've also communicated what a challenging and complex, demanding condition diabetes is, and that people need a lot of support, and a lot of people need support because there's a lot of people out there with diabetes. Probably you all know one person with diabetes at least, and that person might be the one that is experiencing a lot of distress. So you just don't know until you start to ask the questions. There's a strong association between elevated diabetes distress and elevated blood glucose levels. So unless we do something to help people to resolve their distress, then they're going to be heading for the complications that I talked about earlier. They're going to be heading for vision loss and kidney damage and amputations and leg ulcers and so forth. So it's a really serious consequence, but actually the solution for many people is quite simple. And I think that's the message that I hope I've communicated this afternoon. I have a great many thanks to give, and I'm certainly not going to read them all out, but I've worked with some really fantastic people at Warwick, and I've had a lot of my research training at Warwick, so it's been, I've got lots of people there, students and research fellows and senior colleagues, and I've benefited from some brilliant collaborations both in the UK and overseas. And I've got some great new colleagues that I'm really enjoying working with here at King's, and I think I've been very warmly welcomed. Below, some vast array of funders who funded this work, and I'd like also to acknowledge them. So, thank you very much.
very much indeed. I'd like to just thank you on behalf of all of us here for what an absolutely excellent lecture. Now, we will all have taken different things away from this, but there's certainly a few things that have struck me. I mean, I think the first thing is the importance of this subject. You know, long-term conditions is probably the biggest challenge for healthcare and society over the next 50 years or more, particularly with an older and an ageing population. And it seems, you know, from Jackie's lecture that, you know, self-management is the only answer. There really isn't any other. But what's come across to me in this lecture is the difficulties involved in this. You know, I think I was struck by your case studies and the fact that, you know, in one example, somebody thinks about their condition every hour. What should they be doing? You know, the stress and strain of that is quite remarkable, I think, and that, you know, it's just not surprising that so many people just can't do it unless they get some help. And also, the sort of negative impact that can have on people's self-image and their coping and so forth, and leading to demoralisation. And what's clear to me is that Jacqueline's work has really made such a major impact on people's lives, and I think you should be congratulated for what you've done. The second thing that strikes me is really the development of Jackie's career, and how, in fact, you know, her early work in the Sue Ryder homes, and the idea of her, what I think you called emotional caring, and how, in a sense, that emotional caring has come through even in your work today. And in a sense, what I see is it's almost the art of nursing, the art of emotional caring, combined with the science of behavioural change, which you know, is a major contribution of your work. And the third thing that strikes me is, you know, this is an object lesson on how to keep the attention of an audience in a lecture at 6 o'clock at night when drinks are waiting. You know, I do hope, I think it's evidence that here at King's, lectures are not death by overhead. And I'd like our students in particular to take that message away. You know, and also that lectures can be combined with therapy. You have indeed all had a motivational interviewing session here, and of course you will forgive us if we charge you for that. So I'd just like to thank you so much, Jackie. It's been an absolutely excellent lecture. We've all enjoyed it. I'd like to invite you all to chapters where we've got drinks, and if you don't know where chapters is, just follow the students, because my experience is that they're always the first there. And I would like to ask you to join with me to thank Jackie for an absolutely superb lecture in the usual way. Thank you.